Mm. Hello, everyone. Welcome to Wednesday VMR. Uh, I'm very excited for today's case. I'm filling in the big shoes for Charmaine for today, but I'm very lucky to have Ravi co-discussing with me. So thank you. Also, thank you, Julia, for scribing today, and Menahil for doing the teaching point. I always love your teaching points. Last but not the least, we have Sausan presenting a very educational case today. I'm curious to learn from you, Sausan and Ravi. So, uh, Ravi, do you want to say a few words and then we'll give the mic to Sausan?
Absolutely. I'm just so excited to be here and join good friend Mengyu on this Wednesday afternoon. Luckily, I'm off. I just finished a stretch in the ICU step down. So I think rather than do the labor-intensive exercise of taking care of patients on the floor, now do the cognitive exercise along with Mengyu. So excited to learn and see with a case from Sosan. Do you want to unmute and just say hello, Sosan?
Hi, everyone. I'm very happy to be here today and to present a case and listen to Dr. Ravi and Mengyu's awesome discussion as usual.
Okay, well, I look forward to it. Maybe if Julia, you're ready, you can start sharing the screen and then we can get started.
Okay, so starting with the chief complaint, we have a young male who's presenting to the ED due to generalized weakness and fatigue, and I'm gonna stop here.
Yeah, thank you, Sausan. This is a good place to stop because Ravi, we can take turns and I can start with the first aliquot and you can do the next. Yeah, I think so far the chief complaint you get is generalized weakness and fatigue, which usually like I translate to non-specific generalized symptoms. So that could have a lot of underlying differential diagnosis, primarily thinking about inflammation. However, I think as I learn more about this chief complaint, I got to learn how fatigue could indicate a blood problem. So either anemia or inflammation in the blood, like an infection. We have some recent cases where it turns out to be the clue for endocarditis, but it depends on the patient's risk factors, where like blood and the acuity would also help us understand what that means. Um, and then a cardiopulmonary is another category that associated with fatigue. And then in terms of the generalized weakness, it's helpful. Southern told us it's a generalized because weakness, you can always think along the neural pathway all the way from brain, spinal cord to all the way to the end nerve, electrolytes, oxygen supply, nerve, muscle, and peripheral nerve if we go backwards. But here, the generalized really let us focus on the more systemic oxygen demand, electrolytes, and muscle at most if it's a generalized. But yeah, so those are where I'm thinking like for these two chief complaint that we encounter pretty commonly. How about you, Ravi?
Oh, I think that's an absolutely wonderful start. There's just so much to this landscape of weakness. And I think it's incredibly important as to where you start along the spectrum of weakness. So, my first sort of question to a patient, if I'm seeing this patient with weakness, is do you just feel weak, just like the energy has been zapped out of you? Or are you actually weak? Like, can you lift up your arm? Can you lift up your leg? Is there weakness there? So if you go with the first problem, I just feel terrible, right? So then you can sort of decipher or start asking questions along the path of, is there an infection, which can cause weakness? And it's usually generalized, not focal. And then it could be something that could be, like you mentioned, hematologic, cardiovascular, respiratory, but then comes sort of like the psychiatric features. Then comes medications and polypharmacy, which can cause a huge problem with weakness as well. And then you could get other major organ related issues like renal issues, liver failure or injury. But if you go with like, I'm weak because I cannot move a limb or extremity, then you go into the major areas of there's a neurological disorder, there's a muscular disorder, and then like Mengyu just mentioned, inflammation. Inflammation then could also target different areas as well. So that's how so I always had trouble trying to figure out, okay, weakness, discard it because there's something beyond it that is just bubbling to the surface with weakness. But when you start dividing weakness along, like, is it just generalized weakness or is it focal weakness? Then you can target the actual system and it could help you to get to the root of the cause. But I'll leave it at that. And anything else come to mind, Mengyu, before we go back to Sosan?
Yeah, Ravi, I wonder what you think about the young female, another key point Sausan provided to us. But before that, I was able to find like the fatigue, the recent teaching from Ravi about fatigue, where you think about the three categories as we kind of mentioned to like cardiopulmonary, blood that includes hormone, viral infection, and then some intrinsic quantitative, qualitative issues like blood count. And then a brain neuro is another category, like that includes like psychiatric problems, Parkinson or sleep disorder. But I think in a young male, I think thinking less about that. So I think those are the three buckets. But Ravi, I wonder what you think about the young male. How does that change?
That is an absolutely wonderful question, right? A young person, I'm really worried, right? Anytime a young person comes from experience, they have a very good mechanism for compensation, right? So they do not very easily get pushed over the edge. So we have a phenomena in geriatrics called homeostasis. The more things you pile on, the more likely the patient will decompensate and fall over the cliff and show that there's something wrong. With a younger patient, the journey towards the end of the cliff is rather long. Why? Robust physiology, strength, and so on. So protoplasm is intact, and you can tolerate a lot more than maybe somebody who's in the geriatric population, or what's the technical term that we use now in our senior population. So the younger person, I'm very worried because sometimes you bring them in to the hospital and you're like, I'm not quite sure, but you have to observe and see what happens. But if there's any inkling or anything that you can find that's abnormal or really tease out that this could lead to a diagnosis, I think you really have to do the cognitive work, legwork to try and figure out what may be going on. But as far as diseases, yeah, sometimes what do we call in a young person? Bad genes, bad I guess bad genetics, bad substance, and so on. That saying you have to think about as well. So could there be something that could be congenital, genetic, they're young enough that it could manifest in adolescence and in the 20s as well. So yes, I'm worried. What do you think, Mengyu?
Yeah, I agree. I think bad genes, bad luck, bad habits, and yeah. Anyway, let's hear more from Sausan. For example, I'm curious whether this is like more exercise-induced, exercise intolerance kind of fatigue, or I think more details will definitely help. So back to you, Sausan.
Amazing discussion. So this is a 23-year-old male with a history of type 1 diabetes that is complicated with diabetic nephropathy requiring dialysis and hypertension. So he presents with fatigue and weakness of 3 days duration that started initially with nausea and vomiting and chills 1 day after his last dialysis session. His symptoms worsened over the last 2 days that led to decreased oral intake and overall functional decline due to weakness. And he came into the ED with a wheelchair and he requires assistance when moving or going to the bathroom, for example. He denied any fever, cough, shortness of breath, abdominal pain, and his mother denied any episodes of altered mental status. And I'm going to stop here.
I guess I'll take a stab at this new information, Mengyu, and then just pass the mic back to you. But at this juncture, this is going on for quite some time. We're talking about 3 weeks, so subacute process. If we're thinking about, like last week, I tackled a case of neuropathy, so it's not an acute sort of polyneuropathy if we think about neurological disorders, but more of a chronic issue. But we haven't got
3 days.
Oh, 3 days? Oh, sorry, I thought 3 weeks.
Mhm.
Okay, so 3 days will make it acute then in this case. So I take back what I mentioned. So this is very concerning, and we're seeing the patient right at the get-go with this with these conditions. Now, when you bring in the nausea, vomiting, and chills, now you have to wonder, is the answer in the gastroenterological system? And then chills to me, whenever I see patients with chills, I start thinking infection. And where do chills emanate from? You have to go back to the thermoregulatory response in the thalamus. And if there is any sort of infection, bacterial endotoxin, lipopolysaccharides, they can actually upregulate certain interferon, interleukin 6, interleukin 1, and that can alter the thermoregulatory set point in the thalamus. And then you try and increase your temperature, or you increase your temperature, but then your body has to then maintain that, and that's by shivering. You feel cold. So there is this initial set point, and the body then has to catch up, and then you have this shivering. But if the shivering is to the nth degree, you get what's called rigors, and that can sometimes correspond in the literature. If you do a deep dive, it can correspond to bacteremia in a patient as well. So you just do kind of wonder if these chills are secondary to an infection. So again, nausea, vomiting could be non-specific, or this could be the site of where the problem lies. And I wonder if on exam we can actually discover more issues in the gastroenterological system. So is this, if I do the rudimentary work through of this process, the patient has diabetes and is not well controlled, has neuropathy at a young age, has kidney disease, so could they have gastropathy or the uh, gastroparesis that they have as well? So nausea, vomiting could be due to that. But 3 days is usually gradual. I don't think suddenly in 3 days you do develop this. So that is troubling me. But if I put this along the spectrum of diabetic disorders, this could be a diabetic gastroparesis. However, we still have to think of an acute gastroenterological process. Anything else comes to mind, Mengyu?
Yeah, I think I have a couple of reflex thinking when hearing the story about the background of type 1 diabetes, and unfortunately already complicated by a dialysis requirement, ESRD. And also, so when I hear nausea, vomiting in a diabetic, insulin-dependent diabetic patient, and my first thought is, could they have DKA? Because metabolic acidosis could cause fatigue, nausea, vomiting. So I think, and I also remember like in patients with ESRD, on dialysis, the management of DKA is very challenging. It's like, because you cannot give them a bunch of fluids, you can have to, and their clearance of the insulin is also, different from normal people. So I think that's one thing that came to mind. I think checking the blood for that, for sure. And then the chills, I think adding on to that is really, I think we have to rule out infection. And of course, they would be at, higher risk of infection through, related to dialysis, related to the diabetes. And I love Dr. Snyder's rich thoughts in the chat, because I think for a dialysis patient, they have inherent risks. Not only are they more sensitive to certain infections like, Candida, or I think I think the key question, yes, as Rich mentioned, what is their access? Do they have a blood catheter that further increase their make them prone to having a blood infection, as we kind of discussed earlier? And are they still making urine that they could still be at risk for UTI? Yeah, I think definitely assessing the infection there. I don't hear any localizing symptoms to suggest other source of infection yet, but blood is a source we always have to think about. Um, and yes, I think those are my thoughts at this time.
Yeah, Mengyu, it's a great, I guess, progress for this case that you're making. I'm going to springboard from what you said now, because I've sort of mulled on a few things while you were talking. And yeah, just this episode happening right after dialysis. And what essentially happens in dialysis, you essentially take out your blood and you put it through a machine and it comes back, right? And there's ample opportunity along the way that it could get contaminated. It goes through a catheter. The catheter site may not be clean. So you're right, this could be a great way for bacteremia to develop. So along many years of working alongside patients on dialysis, you have to suspect when they come in altered mental status, hypotensive, septic. You have to rule out bloodstream infection. So because the catheter is a great way for infections to spread directly into the blood. Also do an examination of the catheter, and if they have a catheter, when did they have it? Is the site clean? There's various procedures to take care of it. Is there an AV fistula as well, which could be another access way to do it? Shileys are done in the hospital, but we don't discharge patients out with Shileys. They're used in the immediate acute care setting to initiate dialysis. So these things actually, it does, if you put together the breadcrumbs, nausea, vomiting, chills, right after, a day after dialysis, and this patient is extremely immunocompromised, right? So with diabetes, with the kidney issue, this patient's at risk. So they may not come in with a rip-roaring fever. They may not have a rip-roaring leukocytosis. So this patient isn't your typical patient. So you have to be very aware of, or I guess pick up on the clues. This patient may have an infection. So we may not always see the fever from the get-go. You may not have the leukocytosis. You may have on a differential neutrophilia or bandemia. The other day I had a patient with normal white count, no fever, bands of 53 and shakes, group A strep bacteremia. So initially a patient may not declare themselves as having infection, but you still have to have it high up on your list of possibilities. Back to you, Mengyu. Any other thoughts?
Yeah, I was just thinking practically, you might think, why we're doing so much thinking with this limited information, but I think practically it's very helpful as I tell, my residents, because when you're asking the patient's history, you're already starting to build a differential. So like this differential will actually help you do your hypothesis-driven history taking. Like you're going to ask them about localizing symptoms, and you think about what are the most common source of infection. So you ask about pulmonary symptoms, skin symptoms, hepatobiliary GI symptoms, and urine symptoms. And then, so I think this is very helpful too. We practice like being familiar with what are the common sources of infection, and then because that will help us get a more distilled history. So yeah, I think I'll give the mic back to Salsan to tell us more.
Okay, so for his past medical history, other than the diabetes, so he has also retinopathy, and he has previous admissions for DKA. And for his dialysis, he does twice a week sessions via a permacath, and he started the dialysis only like 6 months ago. And another thing is that he is not completely anuric. He does produce some amount of urine. And for his medications, he only takes insulin and lisinopril. And for his otherwise, the history was non-contributory. For the physical examination, the vitals, he was afebrile. His blood pressure was 105/56. Heart rate was 102. Respiratory rate was 23. Saturation was normal. General appearance, he was ill-appearing, dehydrated. He had no rash or erythema around the permacath site or like any rash on his body as well. Neuro exam, he was alert and oriented, no neuropathy. And he had some lower extremity edema. And I'm gonna stop here.
Yeah, wonderful, Alakwa. Thank you, Salsan. I think let's start with the vitals. I noticed his tachypneic, and what that suggests to me, however, his saturation is normal. So what that suggests to me is the patient could be having a metabolic acidosis. So he's having a respiratory as a compensatory increasing the respiratory rate as a compensatory mechanism for that. Heart rate is also fast, which correlates with the fact that he's dehydrated, his volume depleted, and ill appearing. That again makes me worry about something like DKA or infection bacteremia, sepsis. So sepsis or DKA, I think both are possible. Let's see. I was going to say something else, but I looped my mind. But I think sounds like otherwise exam is unremarkable. There's like no localizing exam finding to suggest a source of infection yet. So sealed blood is where our focus is. Low-grade edema, I'd like to know the chronicity of that, whether this could be part of the is it worse from the baseline, assuming the patient has been getting regular dialysis to keep him euvolemic, or is it a localized edema? But sounds like more is like a bilateral edema, which so I think getting to know the chronicity of it and see if there's anything new that would make us think about a new process. Yeah, if Salsa, maybe we could clarify whether it's bilateral or
Yeah. Sorry, yeah, the edema was bilateral, and it's not new, it's chronic, we could say.
Okay, yeah, I think that's very helpful. Yeah, what do you think, Ravi?
Yeah, I think an absolutely wonderful breakdown of the vital signs, like you had mentioned, that the likelihood from the get-go, you mentioned that there could be DKA. So what I was always taught is anytime you have a process like DKA, a withdrawal process or anything, it's not the primary thing. You have to look for what is the driver of that phenomena. So the DKA is being driven by something, which could be non-compliance, could be an intra-abdominal issue, could be sepsis, could be stress, could be myocardial infarction. I've seen numerous kinds of presentations where the DKA, it's evident on the surface, but there's something else in the background. I've had many occasions where patients had ACS and it's silent. Um, with diabetes, you can have neuropathy, so they may not manifest with the chest pain and the radiation down to the left arm or up to the jaw. So you have to be aware and looking for these signals. So I think doing a preliminary workup always of interest, because these patients are on a high speed course to getting ACS, or coronary artery disease, kidney disease, peripheral artery disease, gangrene, and so on. We have retinopathy. We have, unfortunately, all these side effects in a young patient, which is devastating, and which is extremely sad, as the patient probably has not been managed or taken care of, and all of this could have been prevented. Um, but at this juncture, we have to at least stabilize this patient. We're anticipating the pretest probability for DK is high. And if you look, sort of glance at the past medical history, these patients had numerous presentations for DK in the past. So I think anticipating that, getting the appropriate labs, and then deciphering the labs will be key to this. But then doing a timeout to see, is there an issue somewhere? And I think the chat also mentioned we went pretty heavy in on bacteremia, but always go to the other systems, because I had a patient the other week, and patient had hyperbilirubinemia and also had ALK phos, and I'm thinking hepatobiliary, but then they ended up being a urine issue and a stone and hydronephrosis and pyelonephritis. So sometimes you can have two simultaneous things occurring. So what are the most common infections that present to the hospital? And this is going to be atypical, because just take a glance at his temperature. He's afebrile. So on your radar screen, infection still prominent, even if the leukocytosis won't be here when we get the labs from Solsan. But look at the skin, definitely. This patient's in a wheelchair. Could he have decube ulcers? Could he have gangrene? Always take the socks off, look at the toes. We had a case last week where there was between the toes an skin abnormality, so definitely do look between the digits. Look at the respiratory system. He's not coming with cough. He's coming with nausea, vomiting. Could he potentially have aspirated? Question mark. So look at that too. Look at the urinary system, the blood, and also CNS. So is this somebody that we need to worry about for a meningitis and encephalitis? And doing an LP is very invasive, so we really have to think about the pretest probability of this and looking for maneuvers. Sometimes they help, sometimes they don't. Koenig, Brzezinski, but they may not be there as well. So you still have to do the mathematics to determine the likelihood of this condition. But at this point, bacteremia to me is high on the radar screen. Do look at the skin. Actually, you didn't see anything there, right, Sosan? Skin exam.
Yeah, it was clear.
Okay, clear. Okay, good. But always make sure to do that. It's the largest organ of the body, right? So we do have to pay it some respect. But then the labs are going to be very key. And I definitely would like to get some blood cultures as well. And also do go through the motions of decay management if there is a large anion gap in this patient, and put them in, start thinking about putting them in a higher level of acuity, like an ICU/ICU step down. All right, back to you. Anything else, Mengyu, while I was rumbling on?
No, but I just saw some interesting comments in the chat. There was some question about could like removing a lot of osmos in the during dialysis create this. So I think for that, I've only seen one case of dialysis disequilibrium syndrome. I remember in residency, I was paged for a rapid response where someone who had first time dialysis after, having not had that, I think he was like actually being initiated on dialysis for the first time, and his BUN was like 140 or something prior to the dialysis, and then developed altered mental confusion after the dialysis. So I think that's the scenario where you could expect to see that condition. I think in someone who regularly get dialysis, it's probably very uncommon, because you do need to have a big change in your osmosis in the inner blood or BUNs to actually make that brain swelling happen. But yeah, I think we can give the mic back to Selson.
Just one comment. I see the chat started getting heavy in the nausea, vomiting. It was interesting. If we anticipate DK, it's not uncommon. Patients do have that. So if you do look at, I always had a question: why do all my DK patients have abdominal pain? And the metabolic acidosis actually causes spasms within the bowel, and they will have terrible abdominal pain. And as soon as the anion gap closes, the abdominal pain then it resolves. So it's an interesting phenomenon. You see that. So I'm trying to link that to this nausea, vomiting, and if there is gastroparesis, which I'm not sure, but this could be exacerbated by this phenomenon of DK if that is it. But also pay attention to possibly a gastroenterological process like peritonitis, like hepatobiliary disease, and so on. Back to you, Sosan.
Okay, amazing discussion, and I really like the teaching point about like having a low threshold to get blood cultures and like looking for bacteremia. I have a question for everyone, and specifically for Dr. Ravi and Dr. Mengyu, is that okay? So like now we're in the ED, we're establishing the IV access, getting EKG, and we were getting a point of care glucose. And how would the levels of glucose alter your differential?
Yeah, that's a great question. We know like normal glucose, you cannot rule out DKA because you could have a euglycemic DKA. And I think for that, you can see in two scenarios. One is you're on the patient is on an SGLT2 inhibitor, because that will decrease the blood glucose and causing a deficiency in the insulin, action. And then, or if someone has been having advanced diabetes but have been fasting, or is taking some anti-glycemic simultaneous, I think that could also happen. I think I would really rely on checking but I think most commonly you still would see elevated glucose in someone with just type 1 diabetes. But I would definitely rely on blood ketones to test for that. And actually, there was a case on the New England Journal recently talking about euglycemic diabetic ketoacidosis, where I learned that even if the urine ketone is negative or marginally elevated, it only tests for acetone. So like but in the setting of DKA, your ketone actually shifts towards more producing beta hydroxybutyrate from like 3:1 to 10:1. So you actually have more beta hydroxybutyrate that is not detected on a urine dipstick test. So if you really want to confirm, like you have to check blood beta hydroxybutyrate. Like negative urine ketone doesn't rule out that DKA either. Yeah, how about you, Ravi? What do you think about the value of glucose in?
I think you just did a wonderful job going through that. I think the glucose itself won't be a sort of pivot to making the diagnosis, because the DK is a constellation of different things or parameters to make the diagnosis. So, like you wonderfully said, the SGLT2. What's interesting, like the first time I saw that case, I was in ICU step down, and we didn't know what was going on with this patient. And the patient had anion gap, and it didn't come out. Then suddenly, all these papers came out about no euglycemic decay, but it was incredibly tough trying to figure out what this patient had. So I'm sort of having deja vu with this case when you mentioned that. But yeah, I think you have to take the glucose in addition to the other labs to see. And I think it's always important to think about. Sometimes you do see sometimes blood sugar is really high, which could be an HHS. I even had a patient with HHS DK overlap, which can happen as well. So yeah, I'm not sure how to answer this question. I mean, the sugar, if it's normal, we may have to pivot to another thought. Maybe this isn't decay. Maybe there's another acid-base disturbance if that is on the horizon for us from Solsan. But back to you, Solsan.
Yeah, by the way, I just checked my notes just to confirm. I think in addition to the SGLT2, the other is like when someone's very cachexic and having starvation in a critically ill patients with type 1 diabetes or advanced type 2 diabetes. Those two are another scenario for euglycemic decay to happen.
Yeah, I mean, even if there is ketosis, yeah, you're right. I actually run simulations. I have a patient with alcoholic ketosis, thiamine deficiency causing ketosis. So there are other causes of ketosis if that is the case, if there isn't a euglycemic picture here. Back to you, Sosa.
Okay, amazing thoughts. So I'm going to give you the labs, and it's the last aliquot, and after that, I'm going to reveal the final diagnosis. So blood cultures and urine cultures were collected, and they're pending. His glucose levels were 512. CBC was normal with normal differential. Sodium was 132. Potassium was 6. The BUN was 55. Creatinine was 5.6. pH was 7.12. The bicarb was 10. The anion gap was calculated was 22. The beta hydroxybutyrate levels were 5.5. And urine dipstick was positive for ketones and glucose, but no RBCs or white blood cells. And then ECG was done, and it was normal. And chest X-ray was normal as well. And I'm going to stop.
Wonderful. Wonderful presentations, Olsan. This is very expert level presentation of the case, and actually the right details delivered to really be able to process this case. So really give kudos for you preparing or spending the time to prepare this case and presenting it in such a eloquent manner. So the labs, definitely you had mentioned, how's the glucose going to change this scenario? It definitely does change because high on our radar screen was DKA. There is acidosis, there's anion gap. I think the anion gap is, so the bicarb being 10, yep, so it accounts for it if it's down 20, 10, 12. So anion gap will be 12, 10 extra, so it's around the same ballpark. So the DK is accounting for the anion gap that we're seeing. The pH worries me, so definitely 7.12. This patient definitely needs therapy. So this is where we'll start therapy before we start digging in to see why or what flipped the switch or triggered this decay. So with two different scenarios with diabetes, type 2 more, you may have HHS with type 1, you have acidosis. So what will really put the brakes on the acidosis is insulin. So starting the insulin drip will be key here. Once you start the insulin drip, you have to simultaneously give volume to, because these patients have tremendous osmotic diuresis and will be volume deficient. If you look on the other side with HHS, you have a tremendous amount of volume depletion because the serum osm is through the roof in this case. So there you have to give a lot of fluid in this case. Now, there was a good question by Yasmin in the chat. So what do you do with an end-stage renal patient? You can't give tremendous amount of fluid in these patients. So you know what? A end-stage renal patient, a heart failure patient, they have the right to be volume depleted. So what does that mean? That means that you can give fluid, but maybe in a gingerly manner. So giving fluid, watching cautiously in case you fill them up too quickly. But I still would go ahead and give them fluid, but pay attention to parameters and how they're tolerating the fluid. This patient is also, we're kind of lucky because they do make urine. Now, I always wondered, I had these patients that wouldn't go to dialysis and they never come into the hospital with pulmonary edema. Why? Because they make urine, so they're able to remove volume. But if you're an anuric end-stage renal patient, you're not able to make urine, so you just continue filling with volume until you have devastating like blood pressure, volume overload, and so on. So in this case, definitely start insulin, the fluid, put them in a high level of acuity, frequent BMPs to watch the NI gap till it closes. Watch the potassium too. So the potassium here is 6. So implementing insulin in a hypokalemic patient, it could actually make it worse by driving potassium into cells. In this case, the potassium is 6, so you will be fine giving the insulin. So no need to like be cautious with the potassium in this case. Then you do the legwork of what is going to be, what is the cause of this DK. And a lot of times you don't just like, okay, this is DK, I'm managing, the patient should be fine. The white blood cell count is normal. But again, what did we identify this patient with at the get-go? This is an atypical patient that is devastatingly immunocompromised. Diabetes in itself can be immunocompromised state, and also end-stage renal disease. So for that part, and also maybe to go through the landscape of what could be causing this patient's DK episode, I want to hand the mic over to Mengyu.
Yeah, that's such an interesting case, Salsan. So first, I think in terms of the blood gas, I love blood gas analysis. Always follow the steps of first checking the pH, where the pH is low, there's some sort of acidosis, and you check the bicarb, confirming it's a metabolic acidosis. Then if we have the CO2 level in the, our blood gas, we can then see if there's the respiratory component, so here we don't have CO2, so we will skip that. Then we check the anion gap. Anion gap is high, so it's an anion gap metabolic acidosis. Then you see how high it is and do the delta calculation. So here the anion gap increased by 10. This is assuming that the patient's albumin is normal. Even though there's some debate on whether you actually count the albumin, because there's an EAM Create article says you shouldn't really adjust the anion gap normal range based on albumin. But in my own practice, I found that it still applies, because I've had patients who apparently has metabolic acidosis but has a normal anion gap and if you don't count the albumin. So like I think I still calculate albumin based on which is like for every 2.5 decrease in albumin, you would expect the normal range for anion gap to also for every 1 drop in albumin, you expect the normal range of anion gap to decrease by 2.5. But here, let's assume it's normal, then albumin is normal, then the anion gap would just increase by 10 from 12. And so never remember, I don't ever try to remember the range of the normal, like the normal range for different metrics here. I just remember the normal value. So here the anion gap increased by 10 and the bicarb decreased by 14 from the normal value of 24. So I would say the bicarb actually decreased more than the anion gap, which if we want to be really strict, like we can say there's another process that's bringing the bicarb down. And by definition, the process that is bringing the bicarb down without affecting the anion gap would be a non-anion gap metabolic acidosis. So we can say there's a non-anion gap metabolic acidosis component. However, just do like a quick rundown of the causes. I don't see any apparent causes, and it's not a very significant difference, especially if the albumin is low. I don't know this guy's BMI, like if he's already kind of cachectic in some way, then I would expect that maybe they're very similar, the degree of bicarb drop and anion gap. So anyway, so let's just focus on the elephants in the room, which is the the NN-GAP metabolic acidosis. And I think for that, we have the evidence of ketoacidosis with elevated glucose consistent with DKA. But also, I want to make sure, I would usually also check a lactate, make sure there's not a concomitant lactic acidosis suggesting potential underlying sepsis, which I've seen definitely happen, not uncommonly. So anyway, so with the DKA, I think the management is very interesting, as you guys all discussed in the chat and Ravi mentioned. I remember like the last time we had to manage a patient like this. I think first having nephrology on board, having the dialysis ready is really game changing, because then you can basically manage as a normal DKA patient. You can give a lot of fluid and insulin drip, and the fluid rate is really high if you check. So the way to manage these patients, I recommend, if you're going to residency, always go to UpToDate and pull up the algorithm, because I even manage so many DK. I still do that on a routine basis because it always helps me making sure I cover all the component of a DK management, from the choice of fluid, the insulin drip, and the choice of what electrolytes you put in, the potassium. Usually if the here the potassium is high, so we don't have to give them patient potassium yet. But if it's at the upper normal range of the normal of the upper normal range, then from there you'll have to actually start giving potassium. But here I think the question is, if we can get nephrology on board, I think managing as a DK in the normal patients is probably okay. Like they have a conversation with nephrology. If not, I remember last time we had to do this is we ended up, I think the patient at first would still benefit from some fluid given the fact that he's dehydrated. But once you give some fluid, maybe like a liter or two, depending on your assessment, you cannot keep the fluid going. Is if they don't make a lot of urine, then you would have to, what we ended up doing is that we just give the patient a long-acting insulin without further fluid, and just check the patient's glucose every hour and then adjust from there, which is pretty wild. I'm trying to remember why we couldn't give insulin drip. I think that's because there's also, I'm trying to remember why we didn't do the insulin drip, but just give like a long-acting insulin. So I think that's where I think if we have nephrology, would be very helpful in this scenario. But I'm curious to see what you did, Sausan. And Ravi, and do you have anything to add?
Absolutely wonderful discussion. Yeah, it's interesting when you kind of decipher this acid-base disturbance with a renal patient. They already have a different environment within which you have to solve this problem. And then you also have the nausea, vomiting, and the vomiting will induce alkalosis. So that adds another layer to this. So I think at this point, I mean, the major driver of this would be the DKA. So I would implement therapy like you mentioned. I did put a graphic to kind of go through how the complex administration of insulin and the overlap of fluids should be done. But again, this is a different patient, end-stage renal patient. So like you said, be very ginger in your approach and giving small amounts of fluid and watching how they do, and giving that insulin drip. I think the insulin drip will be key, because in this case, it's very important to switch off ketone production. So ketone production can lead to obtundation, can lead to cardiac arrest, can lead to death in the patient as well. So it's vital to switch that mechanism off so that the insulin can drive the glucose that's flowing around into the muscles, into the brain, into the areas that it needs to go in. And then the fluids help with reversing the metabolic disorder that's going on in this patient. Back to you, Solsan.
I'll actually add, thanks, Rich, for your comment in the chat, because I tried to remember the insulin drip, like we couldn't use it last time. As Rich mentioned, it was because you tend to tend to overdose insulin if you put an insulin drip, because the risk of and then the patient could have hypoglycemia later. So I think giving one dose of long-acting insulin to allow it to kind of, combat the glucose, I think that's would avoid that risk.
Right. But what then you also do is then switch the fluids to a small rate of D5 half normal saline to give them a buffer so they don't become hyperglycemic. So there is a nuance, you're right. And there are protocols. So for any interns that are starting, there are protocols in place in a lot of step down units, ICUs, to make this work easier. Because I guess possibly when we trained Mengyu, we had to actually follow those chemistries overnight in the ICU and then switch up the drip based on the glucose at that time. But now it's been remedied with this protocols that they have implemented in many centers, so it makes it easier for us. We can then spend our time working up other patients that may be coming through the doors.
Yeah, I think you mentioned the key. I think Q4-hour lab check is still very important to make sure the electrolytes, potassiums are within normal range. I think for these patients, you also want to check a phosphorus level, because insulin could then deplete their phosphorus, like you can see in repeating syndrome. And if they already have poor nutrition, nausea, vomiting, it could be even lower. So I think checking those things. Yeah. Let's see, Salsa, how did you manage this patient?
Amazing discussion. So basically, this patient was diagnosed with DKA, and no identifiable trigger was found until this day, and especially that he has like recurrent episodes of DKA. And then so basically, the reason why I wanted to share this case is because treatment of DKA in hemodialysis patients is different, as you guys mentioned throughout the discussion. And the key point is to pay close attention to the fluid status of the patient. Because if the patient was anuric and he was hypervolemic, the type of management is going to be different from like the usual DKA management. So we have to pay a close attention to that. And the fact about like, okay, the main treatment here is insulin. And we have to pay close attention to the episodes of hypoglycemia, because like, insulin can like linger more in dialysis patients and end-stage renal disease patients, and the potassium point as well that you both mentioned. And another point that I was reading about is that some like patients with end-stage renal disease who have uremia, the anion gap may not close completely. So the way we can monitor the resolution of the DKA of our patient is through the beta hydroxybutyrate levels in the blood. And that was like one of the learning points for me in this case. But the patient is currently doing well. And I really enjoyed everything you guys mentioned. The discussion was very rich. Thank you very much.
Yes, thank you so much, Salsa, and such wonderful pearls you shared about the management. I also remember a fact that patients with ESRD on dialysis actually are not easy to develop DKA. Like they don't tend to develop DKA. It's like pretty rare. I think because of the fact that they cannot make urine and lose a ton of fluid from that, and their insulin response maybe are more like they tend to not have the insulin deficits maybe. But yeah, I think that's such an important pearl, and sharing the caveats of management of these patients.
Yeah, I also echo what Maggie said. Sosan, you're getting ready for internship. This is such a rich case. I mean, it's so educational for anybody that's starting internship. You will see this. And even this last week, I was in ICU step down. I'm like, where are my DK patients? I usually have a few. So this is sort of like deja vu, because mentally I'm always ready to take on. Actually, there was a DK patient, but my residents were capped. So we do see that quite a bit. And I always make sure, even in spite of this patient not having something in the background, do not get to the point where you just have a diagnosis, but do you have the endpoint diagnosis? What is causing this disorder? And I have had multitude of patients come with very atypical presentations of intra-abdominal catastrophes. Had a patient with peritonitis, had a patient with gallbladder disease, had a patient with a pyelonephritis due to an impacted urethral stone, and then later became very septic once we started treating the DK. So yeah, always look behind the curtain, and especially due to a patient having nausea, vomiting, which can be due to DK. I've had patients develop aspiration pneumonia in when they're presenting to the hospital. So very educational case, and I definitely will give it to my future intern class that's coming in to review and prepare for internship. Thank you.
Thank you again, Salsan, and thank you, Julia, for scribing. And I think we can give the mic to Menahil to share your teaching points.
Wonderful case, Watson, an amazing discussion by Dr. Ravi and Mengyu. At first, we discussed about approach to weakness and fatigue. So fatigue is like associated with systemic conditions, blood conditions. It can be anemia or due to any chronic inflammation. Weakness, it is determined if it's like, it may be due to a low energy that can be a systemic cause or like a true weakness and a neurological or musculoskeletal cause that can be behind it. Then we have to assess like whether this weakness is generalized or it is focal. So if it is generalized, it is mostly due to metabolic disorder or any chronic illness. And if it is focal, then that will be neurologic or muscular pathology. And we also have to keep in mind about the systemic causes that cause weakness and fatigue that include renal or liver failure, certain psychiatric conditions, or medication side effects. Age here play a very important factor. Younger patients have stronger, like with genetic factor and lifestyle habits, will play a role in this, and like they have a much stronger physiological reserve as compared to older adults. That's why older adults are more susceptible to disease-related fatigue and weakness. Then we have like discuss about this chills versus rigors. So chills represents a thermoregulatory response that is triggered by infection or toxins that are mediated by inflammatory cytokines, which are interferon, interleukin-1 and 6. Then we have the rigors that suggest a bacteremia or severe systemic inflammatory response. Patients with a decay or underlying dialysis are at high risk, like due to their immune status or blood contamination. So to like inquire about like what's the source of the infection, the dialysis patient is like whether it's the catheter itself or it's like any pulmonary, derma, GI, urinary cause. So we have to ask the symptoms about related to that history to localize the infection focus. Then we discussed that glucose levels are not sole determinant of decay. We have to check for the potassium levels and iron gaps and other things to label a patient with a decay. And even if the urine ketones are not present in the urine, that will not even rule out the decay. And there are certain causes in where we have idioglycemic decay. So these are two conditions. First, in which patient is taking SGLT2 inhibitors. And second is advanced diabetes, where the patient is also fasting or concurrently taking any anti-hyperglycemics. Then we discuss about approach to decay patients. Like first we have to give the IV fluid. But if the patient is on dialysis or renal failure, we have to be cautious with the IV fluids due to anuric and hypovolemic status of that patient. We have to correct the potassium based on the levels and then initiate the insulin according to the potassium levels. And most important thing is also we have to identify the source of the decay, why like it is like diabetes that is causing it or any ESRD. And we also have to check for any concurrent lactic acidosis that is contributing towards it. Thank you very much.
Thank you so much, Menahil. So blown away by your organized teaching points. Thank you so much. And thank you again, Julia and Salsa, and thank you for everyone for your comments and pearls in the chat. Hope you have a wonderful day. I'll see you next time. And thank you, Ravi. Always a joy to co-discussing with you.
Thank you.